Hi friends, today I will talk about approach to a case of Guillain-Barré syndrome. First is a disclaimer. Caring Talks YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. There is no endorsement for any brand or a company. Guillain-Barré syndrome is acute inflammatory demyelinating polyneuropathy. It is a neurological disorder in which the body's immune system attacks the peripheral nervous system, involving the spinal roots, peripheral nerves, and occasionally the cranial nerves, causing generalized flaccid paralysis. It is a rare but serious post-infectious immune-mediated neuropathy, and it is the most common cause of acute flaccid neuromuscular paralysis. Annual incidence is 1 to 2 per lakh person per year. Male to female ratio is 1.5 is to 1, and incident rate increases from zero point 0.8 in less than 18 years to 3.2 in more than 60 years. Before discussing about the Guillain-Barré syndrome, there is a term called acute flaccid myelitis. It has to be differentiated from Guillain-Barré syndrome. This acute flaccid myelitis is rare but serious neurological condition that causes sudden weakness in one or both limbs due to inflammation in the spinal cord, mainly the gray matter of the spinal cord. It primarily affects the children and is often linked to viral infection, especially the enterovirus D68. The key features of acute flaccid myelitis are sudden onset of limb weakness, and it is often asymmetrical, loss of reflexes in affected limbs, facial weakness, drooping eyelids, or difficulty in swallowing in some cases, respiratory weakness in severe cases, and such patients they may require ventilation. No sensory loss is seen, unlike that of other spinal cord diseases. MRI, if done, it shows spinal cord inflammation, mainly in the gray matter of the anterior horn cell, and CSF may show mild pleocytosis, that is, increase in WBC count. Acute flaccid myelitis can be differentiated from Guillain-Barré syndrome based on the features like onset, weakness, reflexes. Onset in acute flaccid myelitis is sudden, hours to days, but in Guillain-Barré syndrome it is days to weeks. Weakness is asymmetrical, and weakness in Guillain-Barré syndrome is symmetrical. Reflexes are usually absent or reduced, and Guillain-Barré syndrome also there are absent or reduced. Sensory loss is usually absent. Uh, in Guillain-Barré syndrome, mild sensory symptoms may be present. Cranial nerve involvement is possible, leading to facial weakness, swallowing difficulty, and cranial nerve involvement is very common in Guillain-Barré syndrome. It leads to bilateral facial weakness. Respiratory involvement can occur in both. CSF findings in acute flaccid myelitis shows mild pleocytosis, and but in Guillain-Barré syndrome there it will have high protein but normal WBC count. MRI findings are usually normal or mild. Root enhancement is seen in Guillain-Barré syndrome, but gray matter involvement of the spinal cord can be seen in acute flaccid myelitis. Electrophysiological studies will show normal or motor neuron pattern, and in Guillain-Barré syndrome we will get demyelination or axonal damage. So, in acute flaccid myelitis, it is acute asymmetric weakness, gray matter involvement is there, and possibly the patient has a history of viral infection. In Guillain-Barré syndrome, it is progressive, symmetrical weakness. Patient has demyelination on the nerve conduction studies, and CSF shows high protein content. Early MRI and CSF analysis are crucial for differentiation of acute flaccid myelitis and Guillain-Barré syndrome. Coming to the etiology of the Guillain-Barré syndrome, as we know that it is an immune-mediated neuropathy that occurs after an infection or any trigger. The immune system mistakenly attacks the nerves due to molecular mimicry, where the body confuses nerve components with the infectious agents. The common triggers for the Guillain-Barré syndromes are infections, and the most common cause is the infection. It is seen in 70% of the cases. Among the bacterial causes, the Campylobacter jejuni, it is most common and it is associated with severe cases. Mycoplasma pneumoniae can also contribute to GBS. Viral causes are cytomegalovirus, Epstein virus, varicella-zoster virus, herpes simplex virus, HIV, hepatitis A, B, C, E, and Zika virus. The non-infectious triggers are vaccination like influenza H1N1, meningococcal conjugate vaccination. Flu vaccines were initially linked to Guillain-Barré syndrome in 1976, but later studies shows that flu infection itself carries 7 times higher risk of GBS than that of vaccine. Currently, the flu vaccines are considered safe, and the incidence of GBS is only approximately 1 case per million doses. The other factors like trauma, bone marrow transplant, TNF antagonist, isotretinoin, they also contribute important or they also play important role in the etiology of the Guillain-Barré syndrome. So just remember that Campylobacter jejuni associated GBS has a worse prognosis with slower recovery and greater residual weakness. These are the frequency of antecedent events which are seen in Guillain-Barré syndrome. In large case studies, the respiratory illnesses they account for 58% of the antecedent event. Gastrointestinal illnesses contribute about 22%. Then there are respiratory and gastrointestinal illness together they contribute about 10%. Surgery, vaccination, they also contribute to a little to the antecedent event in Guillain-Barré syndrome. The serological evidences are seen in patients who are infected with Campylobacter jejuni, cytomegalovirus, human immunodeficiency virus, Epstein-Barr virus, and Mycoplasma pneumoniae. Coming to the pathophysiology of the Guillain-Barré syndrome, in pathophysiology, the immune system misfire contributes to the pathophysiology of the GBS. As we know that the GBS is an autoimmune disease, it is triggered by the infections like Campylobacter jejuni, cytomegalovirus, Epstein-Barr virus, Mycoplasma pneumoniae. The immune system mistakenly attacks the myelin. Myelin is the protective sheet of the nerves, and due to molecular mimicry, the immune system confuses the nerve component with the infectious agent. Then there occurs demyelination and inflammation. The attacks leads to the inflammation and destruction of the myelin, slowing or blocking the nerve conduction, and this results in progressive muscle weakness, sensory loss, and autonomic dysfunction. Third is the axonal involvement. In most cases, the axon remains intact, but in severe forms, for example, Amman variant, the axonal damage occurs, leading to poor recovery. And last one is the recovery and remyelination. After 2 to 3 weeks, the Schwann cell they start regenerating, the inflammation subsides, and remyelination begins, allowing the gradual recovery. The clinical features of the Guillain-Barré syndrome. Typically, the Guillain-Barré syndromes presents 2 to 4 weeks after the relative benign gastrointestinal or the respiratory illness. The first neurological sign of the GBS is usually paresthesias of the toes, followed by the sudden onset of symmetrical, ascending, progressive bilateral weakness, sensory loss distal to the proximal throughout the body. Symmetrical weakness is the hallmark of the Guillain-Barré syndrome. The weakness usually starts in the lower limbs but may start in the upper limbs or the facial muscles in about 10% of the patient. Flaccid paralysis of the proximal muscle is more common as compared to distal muscles, and most form of the GBS there is greater loss of motor function than the sensory function. Severe respiratory muscle weakness may lead to requirement of the ventilatory supports in 10 to 30% of the cases. Neck flexion weakness, if present in a patient, it may indicate the need for intubation. Patient will have decreased or absent deep tendon reflexes in affected arms or the legs, and it is found in 90% of the patient at presentation and in all patients with disease progression. Pain is an often under-recognized symptom of the GBS. It is due to the nerve root inflammation, and it is mostly felt in the back and in the extremities. and it is seen in acute phase in two-thirds of the patients and may persist up to one-third till 1 year. Oropharyngeal weakness eventually occurs in 50% of the cases. The dysphagia due to glossopharyngeal vagus and hypoglossal nerve involvement is also seen. Facial nerve palsies occur in more than 50% of the cases. Facial diplegia, that is bilateral facial weakness, is due to cranial nerve involvement. The oculomotor weakness occurs in about 15% of the cases. GBS usually progresses over 2 weeks, and by 4 weeks after the initial symptoms, more than 90% they have reached peak within 4 weeks. Dystonia occurs in approximately 70% of the cases, and dystonia and dysautonomia. And patient may have diarrhea, constipation, hypotension or hypertension, bradycardia or tachycardia. Patient may have urinary retention, reversible cardiomyopathy, and Horner syndrome features can be seen in some of the patient. The unusual features of the GBS include papilledema, facial myokymia, hearing loss, meningeal signs, vocal cord paralysis. Autonomic dysfunction can cause arrhythmias and blood pressure instability, necessitating the ICU monitoring. SIADH, which may be due to autonomic involvement, is also seen in few patients of GBS. Coming to the GBS variants, the common subtypes are acute inflammatory demyelinating polyradiculoneuropathy, that is AIDP, acute motor axonal neuropathy, that is AMAN, acute motor sensory axonal neuropathy, that is AMSON. The rare variants are Miller-Fisher syndrome, ataxic variant, pharyngeal cervical brachial variant, multiple cranial neuropathies, facial diplegia, paraplegic variant, acute pain, pan-dysautonomia. The coming to the variants of the Guillain-Barré syndrome, just a brief. First is the acute inflammatory demyelinating polyneuropathy, that is AIDP. The clinical features are progressive ascending weakness, most commonly starts from the legs, then spreads to the arms. Areflexia, sensory symptoms like numbness, tingling. Autonomic dysfunctions can be seen in the form of BP fluctuation, arrhythmias. In investigation, the CSF will show high protein, normal WBC count, that is albumino, cytological dissociation. Nerve conduction studies and electromyography will show demyelination in the form of prolonged F waves, conduction block, slowed conduction velocities. Second is the acute motor axonal neuropathy. This is AMAN variant. It is an axonal variant. The clinical features are pure motor weakness without sensory symptoms, rapid progression, often more severe than the AIDP, common in children and young adults, especially in Asia and South America. It is strongly associated with Campylobacter jejuni infection. DTRs are occasionally preserved in AMAN. Sensory nerves are not affected. In investigation, nerve conduction studies, EMG studies will show axonal degeneration, that is reduced compound action potential, normal conduction velocity, absent conduction block. CSF may or may not show albumino cytological dissociation. Coming to the acute motor and sensory axonal neuropathy, that is the AMSON. It is a severe axonal variant. The patient will have severe motor and sensory involvement, marked axonal degeneration causing delayed and incomplete recovery. It has a poor prognosis than AMAN and AIDP. Severe autonomic dysfunction is possible. In nerve conduction studies and electromyographic studies will show axonal degeneration affecting both motor and the sensory nerves. In AMSON, the motor and sensory responses are frequently severely reduced or absent on electrodiagnostic studies. Coming to the Miller-Fisher syndrome, that is there is involvement of the cranial nerves. It is a cranial nerve variant. The clinical features are the classical triads in the form of ophthalmoplegia, ataxia, areflexia. Facial and bulbar palsy is common. It is often post-infectious, linked to anti-GQ1B antibodies. And when we do investigation, we will get anti-GQ1B antibodies positive in 90% of the cases. Nerve conduction studies may show mild sensory nerve involvement. MRI brain is normal, or it may show brainstem abnormality or cranial nerve enhancement. Next is the Bickerstaff brainstem encephalopathy. It is again a CNS variant of MFS. The clinical features are ophthalmoplegia plus ataxia and altered consciousness. And here we get hyperreflexia, unlike the Miller-Fisher syndrome where we get areflexia. The investigations are anti-GQ1B1 antibodies are positive. MRI brain may show brainstem involvement associated with anti-GQ1 antibodies and can respond to IVIG and plasma exchange. Next is the pharyngeal cervical brachial variant. Here, patient have weakness of the face, pharynx, neck, and the arms. Legs are usually spared, and in the investigation, we get anti-GT1A antibody positivity. Nerve conduction studies and EMG studies shows the features similar to AIDP or the axonal variant. Next variant is the paraparesis. Here we get weakness limited to lower limb at presentation. Minority of the patient they experience some arm weakness over the course of illness. Most patients they have reduced or absent arm reflexes, and approximately 90% have abnormalities in the upper extremities on electrodiagnostic studies. Other variants are acute pan dysautonomia. It is a rare subtype with rapid onset of severe orthostatic hypotension. Patient will have heat intolerance, anhidrosis, dry eyes, dry mouth, fixed pupil, fixed heart rate, bladder or bowel disturbances. The deep tendon reflexes are usually absent with preserved motor and the sensory system. Anti-ganglionic receptor blocking antibodies are elevated in all the autoimmune autonomic neuropathies. Pure sensory GBS, here we get involvement of the large sensory fibers. Patient will have sensory ataxia, reflexes are absent, and there may be minor motor involvement. Another variant is acute painful small fiber neuropathy. It is a rare variant and is a corticosteroid responsive. Unlike other variants, antecedent cytomegalovirus infection results in sensory predominant GBS. So this chart shows the key investigation in various type of GBS variants which I have already discussed. This is the clinical picture showing GBS variant with their clinical presentation, frequency of presentations. How do we evaluate the case of Guillain-Barré syndrome? First is the clinical assessment in the form of history and the examination. In history, we will get progressive ascending weakness. Firstly, the legs are affected, followed by arms, then respiratory muscles. Patient will show areflexia, loss of deep tendon reflexes. Sensory symptoms in the form of numbness, tingling can be seen, but they are less prominent. Autonomic dysfunction like BP fluctuation, arrhythmias, urinary retention can be seen. History of recent viral or bacterial infection, for example, Campylobacter jejuni, cytomegalovirus can be there. On examination, the motor system examination will show symmetrical weakness, areflexia. Sensory examination will show mild loss except in Amson variant. Cranial nerve involvement or their examination may show possible facial or the bulbar involvement. And when we do the respiratory system examination, we have to assess the force vital capacity for impending respiratory failure. And in the investigation, the CSF analysis, that is lumbar puncture, is very crucial investigation. It will show high protein with normal WBC. It is called albuminocytological disassociation. It can be normal in the first week of the illness. Then we have nerve conduction studies and electromyography. In AIDP, we will get demyelation, that is decreased conduction velocity, conduction block, prolonged F waves. In Amman and Amson axonal degeneration, we will get decreased CMAP amplitude, normal conduction velocity. The antibody testing can be done in specific variant, though they are not very useful. Anti-GQ1 antibodies are positive in Miller-Fisher syndrome. Anti-GT1A antibodies are positive or seen in pharyngeal cervical brachial variant, as I have already discussed. Other tests can be done to rule out the various differential diagnosis. For example, MRI spine with contrast. It is done to exclude the transverse myelitis, spinal cord lesions. The presence of nerve root enhancement on gadolinium enhanced MRI is a non-specific but sensitive feature of GBS and can support the GBS diagnosis, especially in the young children in whom both clinical and electrophysiological assessment can be challenging. The blood tests like CBC, LFTs, RFTs, electrolyte, HbA1c can be done to rule out the metabolic causes. The infectious workup for Campylobacter jejuni, CMV, Epstein virus, HIV can be useful. Monitoring and prognosticating the GBS is very important. In monitoring, we have to do the respiratory assessment, We have to monitor the forced vital capacity. If it is less than 15 ml per kg, then patient may need intubation. Modified Erasmus GBS outcome score is used to predict the prognosis. Autonomic monitoring is very important in the form of BP, heart rate, ECG for dysautonomia. So this is the diagnostic criteria for Guillain-Barré syndrome. It was developed by the National Institute of Neurological Disorders and Strokes, and subsequently it was modified in review papers. The essential features for diagnosis are progressive symmetrical weakness in both legs and the arms, absent or reduced reflexes in affected limbs at some point during the illness. The supportive features are progressive phase, which lasts from few days to 4 weeks, usually less than 2 weeks, symmetrical symptoms on both sides, mild sensory symptoms absent in pure motor variants, cranial nerve involvement, especially in the bilateral facial weakness, autonomic dysfunctions, for example, in the form of BP instability, heart rate changes, pain in the muscles or the nerves related. CSF may show high protein with normal WBC, and it could be normal in early diseases. Nerve conduction studies may show features of motor or sensory motor neuropathy, which may be normal in early stages. The red flags are the features that cast doubt on GBS diagnosis. For example, if we get high WBC count and CSF that is more than 50 cells per microliter, we should consider infection. Markedly asymmetrical weakness, usually for GBS, it is usually not seen in GBS. Bladder or bowel dysfunction at the onset or persistent during illness. We have to consider the transverse myelitis. Severe respiratory weakness with minimal limb weakness at onset is atypical. Sensory loss with minimal weakness at onset. We should consider sensory neuropathy. Fever at onset suggests infection rather than GBS. Sharp sensory level. We should think of spinal cord pathology. Hyperreflexia or extensor plantar response, that is Babinski sign. It suggests the CNS involvement. Slow progression beyond 4 weeks. We should think of chronic inflammatory demyelinating polyneuropathy. If the patient presents with altered consciousness, except in Baker's-Stuff, brainstem encephalitis, these are all red flag signs which are helpful to exclude the diagnosis of GBS. So the key takeaways are GBS usually presents with progressive symmetrical weakness and areflexia. CSF will show high protein, normal WBC, and nerve conduction studies may support the diagnosis but may be normal in early course of illness. We should always consider the alternative diagnosis if there is asymmetry, if we get sensory level or patient presents with fever or hyperreflexia. So the differential diagnoses are acute polyneuropathies because of hepatic porphyrias, critical illness, polyneuropathy, hypothyroidism, diphtheria, HIV, vasculitis, sarcoidosis, toxins like arsenic, thallium, organophosphates, lead, neurotoxic fish and shellfish poisoning, vitamin deficiencies like B1, B12, E, polyradiculopathies, that is inflammatory or neoplastic meningoradiculopathies, Lyme disease, Lyme radiculitis, CMV, lumbosacral radiculomyelopathy, HIV, Epstein-Barr virus, varicella zoster virus causing polyradiculopathies, disorders of neuromuscular junctions like myasthenia gravis, crisis, Lambert-Eaton-Mercer syndrome, snake bite, tick paralysis, botulism, organophosphate poisoning, myopathies because of hypokalemia, hypophosphatemia, rhabdomyolysis, drugs like chloroquine, amitin, statins, polymyositis, critical care myopathy, anterior horn cell disorders like poliomyelitis, West Nile fever, rabies, Japanese encephalitis, CNS disorders like transverse myelitis, basilar artery thrombosis, rabies, Wernicke's encephalopathy, sarcoids, Sjogren, and others. So we have to differentiate the Guillain-Barré syndrome from these differential diagnoses. When should we admit the patient to ICU? The evolving respiratory distress with imminent respiratory insufficiency, severe autonomic cardiovascular dysfunctions, for example, arrhythmias, or marked radiation in blood pressure, severe swallowing dysfunction, or diminished cough reflexes, or rapid progression of the weakness. As all these conditions, they suggest us that we should admit the patient in ICU, means evolving respiratory distress with imminent respiratory insufficiency, autonomic cardiovascular dysfunction, severe swallowing dysfunction, or diminished cough reflex. A state of imminent respiratory insufficiency is defined as clinical signs of respiratory distress, including the breathlessness at rest or during talking, inability to count to 15 in a single breath, use of accessory respiratory muscles, increased respiratory or the heart rate, vital capacity is less than 15 to 20 ml per kg or less than 1 liter, or abnormal arterial blood gas analysis report, pulse oximetry measurements. If they are abnormal, it shows that patient needs admission to ICU. Up to 22% of the patients with GBS, they require mechanical ventilation within the first week of admission. Patient at high risk of respiratory failure must be identified as early as possible. The IRAMS GBS respiratory insufficiency score prognostic tool, it was developed for this purpose, and it calculates a probability that the patient will require ventilation within a week of assessment or not. The risk factor for prolonged mechanical ventilation includes the inability to lift the arms from the bed at 1 week after the intubation, and axonal subtype or unexcitable nerves in the electrophysiological study. Early tracheostomy should be considered in patients who have these risk factors. This is the Erasmus GBS respiratory insufficiency score. It calculates the probability that the patient with GBS will require the mechanical ventilation within a week of assessment, and this score of 0 to 2 indicates the probability of going requiring the ventilation is 4%. If the score is 3 to 4, it indicates that uh, there are 25%, 24% chances that patient will need mechanical ventilation within a week. And if the score is 5 or more than 5, it indicates the risk for mechanical intervention or intubation is 65%. The Medical Research Council's sum score is the sum of the score of the MRC scale for muscle weakness of the bilateral shoulder abduction, elbow flexion, wrist extension, hip flexion, knee extension, and ankle dorsiflexion. A higher MRC sum score denotes increased disability up to maximum. A higher MRC score shows increased disability, and it is the maximum score is 60. So when should we start the treatment? Uh, Usually we give immunomodulatory therapy. It should be started if the patients are unable to walk independently for 10 minutes, and if there are evidence of treatment, if the evidence on treatment efficacy in patients who can still walk independently is limited, but the treatment should be considered, especially if these patients display rapidly progressive weakness or other severe symptoms such as autonomic dysfunction, bulbar failure, or the respiratory insufficiency. Clinical trials, they have demonstrated that a treatment effect for intravenous immunoglobulin when started within 2 weeks of the onset of the weakness, and plasma exchange when started within the 4 weeks, and we get good response. Beyond these time period, the evidence on efficacy is lacking. The IV immunoglobulins are given in a dose of 0.4 gram per kg body weight daily for 5 days, and plasma exchange is given as a 200 to 250 ml plasma per kg body weight in 5 sessions for about 10 days. These are equally effective treatment for GBS, as IVIG is also easier to administer. Generally, it is more widely available than plasma exchange. It is usually the treatment of choice. So IVIG is the treatment of choice. Antimicrobial or the antiviral treatment can be considered in patients with GBS who have ongoing infection. However, the preceding infection have usually resolved before the onset of the weakness. So these IVIG and plasma exchange, these are called disease modifying therapies. They reduce the mortality from 30 to 5%, and indications are the non-ambulatory patients, that is a patient who is unable to walk independently for 10 minutes, who are within 4 weeks of symptom onset, ambulatory adult patient with GBS who are not yet recovering within 4 weeks of symptom onset, who the patient who display rapidly progressive weakness, patients who display other severe symptoms such as autonomic dysfunction, bulbar failure, or respiratory insufficiency. All these patients, they require either uh, IVIG or plasma exchange. Coming to IVIG, few words. IVIG is effective as plasma exchange for the treatment of GBS. It is given for 5 days at the dose of zero point 0.4 grams per kg per day. The mechanism of action is anti-idiotypical antibodies supplied by the IVIG have potential to bind and neutralize the pathogenic antibodies. Side effects include aseptic meningitis, rashes, AKI because of sucrose containing products, congestive heart failure, and rarely the patient may have hyperviscosity leading to stroke, headache, MI, or CVT. The contraindications for IVIG are congenital IgA deficiency, congestive heart failure, patient with CKD especially due to diabetic mellitus, or patient has history of hyperviscosity. The treatment effect of IVIG demonstrated till 2 weeks of the onset and plasma exchange till 4 weeks of the onset. Combining IVIG with plasma exchange does not appear to be beneficial for patient with IVIG. So we have to give either IVIG or plasma exchange. Since IVIG is easily available, so we can give IVIG. Coming to the plasma exchange, the mechanism of action of plasma exchange is removal of circulating antibodies, complements insoluble biological response modifier. Plasma exchange is usually given for 5 cycles over 10 days, and dose is 200 to 250 ml plasma per kg body weight in 5 sessions. 4 exchanges were superior in clinical trial. 4 exchanges were superior to 2 in patients with moderately severe GBS. However, in subjects with severe disease requiring mechanical ventilation, 6 exchanges were not superior compared to the 4. So mild GBS show benefit even with 2 plasma exchange also. However, the mild GBS patients do not require plasma exchange. The plasma exchange was most effective when started within 7 days of the symptom onset, but has been found to be beneficial up to 4 weeks. The complications of plasma exchange are hypotension, catheter-related sepsis, hematoma, pneumothorax. Contraindications are active sepsis, active bleeding, severe cardiovascular instability. Other treatment options like corticosteroid, prednisolone, they are not effective in GBS, whether alone or combined with IVIG or other. Treatment of GBS variants, pure MFS, they are relatively mild. They have relatively mild disease course and they mostly recover completely without treatment within 6 months. Therefore, treatment is generally not recommended in this patient group, but patients should be monitored closely because of subgroups can develop limb weakness, bulbar or facial palsy, or the respiratory failure. Patients with BBE, that is Bickerstaff encephalopathy, patients Bickerstaff brainstem encephalopathy, it is a severe disease. Here we can require IVIG or plasma exchange. For other clinical variants, no evidence regarding treatment is currently available, although many experts will administer IVIG or plasma exchange. Patients who are pregnant women, neither IVIG nor plasma exchange are contraindicated. However, the plasma exchange requires additional consideration and monitoring. IVIG may be preferred in children. Greater discomfort and higher rates of complications of plasma exchange than IVIG in children. IVIG is usually the first and line therapy for the children with GBS. Some pediatric centers they administer IVIG at a dose of 2 gram per kg over 2 days, and transfer related fluctuations. Treatment related fluctuations were more frequent within 2 days regimes. How do we monitor the disease progression? A regular assessment is required to monitor the disease progression and the occurrence of the complication. Routine measurements of the respiratory function is advised. These respiratory measurements can include uses of accessory muscles, counting during aspiration in full capacity inspiratory breath, that is single breath count of less than 19 indicates a requirement of mechanical ventilation. Following parameters, they warn of impending respiratory arrest and are indication for intubation, and this formula or the rule of 20 30 40 is followed. That is, force vital capacity less than 20 ml per kg, or when there is decline of the force vital capacity by 30% from the baseline. Maximum inspiratory pressure less than 30 centimeter of water. Maximum expiratory pressure less than 40 centimeter of water. Muscle strength in the necks, arms, legs should be assessed using the Medical Research Council grading scale. Patient should be monitored for swallowing and the coughing difficulty. The last autonomic dysfunction should be assessed by electrocardiography and monitoring of the heart rate, blood pressure, and the bowel and bladder function. Up to two-thirds of the patients, up to two-thirds of the deaths of the patient with GBS occur during the recovery phase, and they are mostly caused by cardiovascular and the respiratory dysfunction. Therefore, the clinician should stay alert during the phase and monitor the patient for potential arrhythmias, blood pressure shifts, or respiratory distress caused by the mucus plugs. This monitoring is especially important in patients who have recently left the ICU and in those with cardiovascular risk factors. How do we manage the early complication? As we know that Guillain-Barré syndrome can lead to severe complications, some of which are common in bedridden patient. The general complication in bedridden patient are pressure ulcer. We have to prevent with frequent repositioning and the skin care. Hospital-acquired infection, for example, pneumonia, UTI, prevention can be done with good hygiene, early mobilization, infection control, deep vein thrombosis. We have to use compression stockings and anticoagulation. GBS specific complications are for bulbar palsy. Patient will have difficulty swelling, risk of aspiration pneumonia is there. We should consider NG tube feeding. Patient with facial palsy, the risk of corneal ulceration is very common. We should use artificial tears and their eye protection. Limb weakness will lead to risk of contracture, heterotopic ossifications, and pressure palsies. Early physiotherapy and splinting will be helpful. Such patient needs psychological and sensory consideration. The pain, anxiety, depression, hallucination are common and should be actively addressed and managed. Patient remains fully conscious despite paralysis, so always communicate clearly and explain procedure to reduce the stress. Multidisciplinary approach will require optimal care involving nurses, physiotherapists, rehabilitation specialists, and occupational speech therapists. How do we manage the clinical progression? In the if there is insufficient response to the treatment in GBS, as we know that 40% of the GBS patients do not show improvement within 4 weeks of receiving IV, IG, or plasma exchange. This does not mean that treatment is ineffective, as the disease may have worsened more without it. Retreating or switching treatment can be considered, but there is no strong evidence that this improves outcome. A clinical trial is ongoing to evaluate whether the second dose of IVIG is beneficial or not. How do we treat the treatment related fluctuation? It occurs in 6 to 10% of the patient within 2 months after initial improvement or stabilization. Treatment related fluctuation must be distinguished from the cases where there is no initial response to the treatment. This is likely due to a treatment effect weaning off while inflammation persists. Repeat IVIG or plasma exchange is commonly done in treatment-related fluctuation, though the evidence is limited. Patients with chronic inflammatory demyelinating polyneuropathy, 5% of the GBS patients they develop chronic form with repeated relapses, and if this is suspected, if the symptom worsen after 8 weeks or the patient has 3 or more treatment related fluctuation. These cases they may require long-term immunotherapy. So the key takeaways are some GBS patient may not respond quickly or may relapse. Close monitoring is needed and further treatment may help, but strong evidence is lacking. How do we predict the outcome in GBS? Most GBS patients recover well, even those who are tetraplegic or on mechanical ventilation for a long time. 80% they regain independent walking within 6 months. The modified Erasmus GBS outcome score helps predict the recovery and the chances. Death occurs in 3 to 10% of the cases, mainly due to cardiovascular or the respiratory complication, which can happen in both acute and recovery phases. High risk of death is seen in older age and patients who have severe heart disease at onset. Long-term issues in the form of neuropathic pain, weakness, fatigue are common but can improve even after 5 years. Recurrent GBS is rare. It is seen in 2 to 5% of the cases but still higher than the general population. GBS and vaccination. Some vaccines carry a warning about GBS, but GBS is not a strict contraindication for vaccination. If the patient had a GBS within the last year or after the previous vaccine, consult an expert before vaccinating. The benefit of vaccination, for example, influenza vaccine in elderly patients should be weighed against the very small risk of recurrences. How do we plan the rehabilitation in GBS? Patient recovering from GBS may face long-term issues including motor and sensory deficit because of incomplete recovery. Patient will have fatigue, pain, physiological stress, psychological stress in the form of anxiety and depression. For pain management, and as we know that chronic pain affects 30% of the GBS patient even after 1 year, and it may last for more than 10 years. Pain may present as muscle pain, back pain, lump pain in the limbs, painful paresthesia, joint pain, radicular pain. The possible causes of the muscle or the joint pain is due to immobility, and the neuropathic pain is due to nerve regeneration or the persistent nerve damage. So we should encourage the immobilization, encourage the mobilization. We can use neuropathic pain medication in the form of gamma pentinoids, tricyclic antidepressant. We should consider analgesics for nociceptive pain. Psychological support is required in the patient who have sudden paralysis, as we know that sudden paralysis can be traumatic, leading to anxiety and depression. Early recognition and management are crucial as mental health affects the physical capacity. The helpful strategies are psychologists or physio psychiatrist referral if needed, reassurance about the good prognosis and low recurrence rate, that is 2 to 5%. Support group, for example, GBS, CIDP Foundation International for peer guidance. For pain control, we give carbamazepine, gabapentin, pregabalin, tricyclic antidepressant, analgesics or NSAIDs, narcotic analgesic, epidural, morphine, and rehabilitation is done in the form of chest physiotherapy, frequent suctioning, splintering, splint for fibular compression, DVT prophylaxis. Patient should be encouraged high calorie protein diet in the beginning as enteral feeding. Acute phase rehabilitation, individual program of gentle strengthening involving isometric, isotonic, isokinetic, and manual resistive and progressive resistive exercises are recommended. Proper limb positioning, posture, orthotics, as well as nutrition is very important. Exercise program involving the range of motion exercises, stationary cycling, walking, strengthening training have been shown to improve the physical fitness, walking ability, and the independence in the activity of daily living. So complications seen with the GBS are choking because of if patient has complaints of choking, we should think of bulbar palsy. If patient has cardiac arrhythmia, they are very common in all patients. Hospital acquired infection because of pneumonia, sepsis, or urinary tract infection can be seen because of bulbar and the facial palsy, immobility, bladder dysfunction, mechanical ventilation, pain and tactile allodynia, delirium, depression, urinary retention, constipation, corneal ulceration, hyponatremia, pressure ulcer, compression neuropathy, limb contraction, ossification. These are all the complications of the Guillain-Barré syndrome. These are the factors which carry poor prognosis. For example, older age, more than 60 years, rapid onset, less than 7 days prior to presentation, severe muscle weakness on admission, patient who needed ventilatory support, and average distal motor response amplitude reduction to less than 20% of the normal, preceding diarrheal illnesses, recent CMV infection, hyponatremia. Relapses are seen in 5% of the patients. Treatment-related fluctuations are seen in 6 to 10% of the patients in GBS, and they are defined as disease progression occurring within 2 months following the initial treatment, induced clinical improvement, stabilization, and relapses not as severe as the initial progressive phase of GBS prior to the treatment. About 2 to 5% of the patients initially diagnosed will develop CIDP. The long-term outcome of the patient of GBS is proportional. Uh, GBS walk independently at 6 to 12 months after diagnosis approximately. Proportion of the patient with GPS who walk independently at 6 and 12 months after diagnosis approximately 80 and 84% respectively. At 1 year, full recovery of motor strength occurs in about 60%, while severe motor problem persists in about 15% of the cases. Approximately 5 to 10% of the patient with GBS have a prolonged course with several months of ventilatory dependency and very delayed and incomplete recovery. 60 to 80% are able to walk independently 6 months after the disease onset with or without treatment. Within 1 year of the diagnosis, approximately 3 to 7% they die despite the intensive care Of course, who become ventilator dependent, about 20% will die. Causes of death include ARDS, sepsis, pulmonary emboli, unexplained cardiac arrest. Up to two-thirds of the deaths from the patient with GBS occur in the recovery phase and mostly caused by the cardiovascular and the respiratory dysfunction. Approximately 15% have mild condition and they remain ambulatory and recover after few weeks. 5 to 20% of the patient they have a fulminant course and they develop flaccid quadriplegia. Recurrent GBS accounts for 2 to 5% of the patient, which is higher than the lifetime risk of GBS in general population. Prior GBS is not a strict contraindication for vaccination. We should avoid vaccination within 1 year of GBS or who previously developed GBS shortly after receiving the same vaccination. This is the stepwise approach how to we diagnose and treat the GBS. When we should we suspect GBS: rapidly progressive bilateral limb weakness, hypo or areflexia, facial or bulbar palsy, patient who came with ophthalmoplegia or ataxia. How do we second step is how to diagnose, check the diagnostic criteria, exclude other causes, consider routine laboratory tests, CSF examination, electrophysiological studies, when to admit in the ICU, when one or more is met, rapid progression of the weakness, severe autonomic or swallowing dysfunction, evolving respiratory disease, when egress is more than 4, when to start the treatment, when one or more are met, when inability to walk more than 10 minute independently, rapidly progression of the weakness, severe autonomic or swallowing dysfunction, respiratory insufficiency. Step number 5 is treatment option. We have intravenous immunoglobulins given in the form of 0.4 gram per kg daily for 5 days, plasma exchange given as 200 ml per kg for 5 sessions. Then next step is the monitoring. We have to regularly assess the muscle strength, respiratory function, swallowing function, autonomic function like blood pressure, heart rate, rhythm, bladder and the bowel control. The early complications are choking, cardiac arrhythmia, infection, deep-vein thrombosis, pain, delirium, depression, urinary retention, constipation, corneal ulceration, dietary deficiency, hyponatremia, pressure ulcer, compression, neuropathy, limb contractures. Clinical progression is assessed. Treatment related fluctuation, we have to see we have to repeat the same treatment, no initial response or incomplete recovery, no evidence of repeated treatment. Long term care is in the long term care, the predicting outcome are we have to calculate the MEGOS on admission. Recovery can continue for more than 3 years after the onset. Recurrence is rare and it is seen in 2 to 5% cases. And the last step is the rehabilitation. We have to start the rehabilitation program early. We have to manage the long-term complaints like fatigue, pain, psychological distress. We have to contact the GBS patient organization. So how do we manage the GBS? If patient fulfills the clinical criteria, we have to do the nerve conduction studies and CSF analysis. If the CSF analysis and nerve conduction studies are normal, we can repeat it after 1 week or we can think of other diagnosis. If nerve conduction studies and CSF abnormal, then it means the diagnosis is considered confirmed. We have to monitor the bulbar function, BP, force vital capacity every 4 to 6 hours. We have to assess the clinical severity. If the patient walks unassisted and if there is no progression, we can do conservative supportive treatment. If the patient walks with support or bend bound and his force vital capacity bed bound and symptoms duration is less than 30 days, in such patient will need human immunoglobulin. And if the patient's force vital capacity is less than 12 to 15 ml per kg, such patient will directly need mechanical ventilation and we can think of plasma exchange. This was all about uh, management of a case of Guillain-Barré syndrome. How do we approach it? What is the etiology? What is the pathophysiology of the Guillain-Barré syndrome? What are the different variants? How do we diagnose a case of GBS based on history and clinical examination on the bedside? Then we have CSF analysis, nerve conduction studies, imaging, though it has a little role. And the treatment, that is IVIG and the plasma exchange, they play an important role in the treatment of the Guillain-Barré syndrome. And further monitoring, for the monitoring of the progression, and how do we prevent the complication, rehabilitation of the patients. This is all about the Guillain-Barré syndrome. Your work is not just about treating the disease, it is about the restoring hope. Thank you. Keep learning.